How are you doing, guys? Basically, we are gonna discuss a little bit about composite today. I'm from Brazil. This is my personal contact. I have the Instagram, and also I have this professional Instagram, and we're gonna have like a few minutes to discuss the restorative procedure. So basically, I'm gonna discuss anterior and posterior restorations. Okay, I'm from Brazil. Basically, I am so far lecturing and teaching at NYU at biomaterials and biomimetics department, and we are working pretty much on research on composites and ceramics. But part of the time I am still in Brazil. I have a clinic. I have my private practice here in the south of Brazil. This is my clinic. So tonight, actually, I'm here. And the first part of the lecture is going to be about the anterior restorations. Basically, the way that we manage the anterior restorations with composite. And what we always discuss about this is that I will begin with a clinical case. This was done with a very old composite. This was the previous composite before the Empress Direct. The name was Four Seasons. And I want you to download this app in iTunes or Google Play, and you can check this video, this step-by-step of the video in this app. We changed the shape and the size of the tooth. If you see the clinical case, before the patient used to have a very old composite. She wanted to increase the length of the central incisors, lateral as well, change the size and the shape of the canine. And also, she wanted to change with composite. She didn't want to replace that with ceramics at that time. So the way that we think about anterior restoration with composite is that we are able to change, and also we are able to modify the shape and the size of the tooth with composite, being more conservative than the ceramics approach. So basically, this was the Four Seasons, the composite that came before the Empress Direct. And the video that you're gonna see basically show you the way that we manage, the way that we work with composite. So the first question that I have is that, okay, can we change the size and the shape of the tooth? We can use composite for that. We can avoid sometimes the use of ceramics. And if you check the final outcome and the result of the composite is pretty good. Always the question is how we keep this composite, how we keep the result, how we can keep this surface polished during the time. So the first question that I always have with composite is, I know that composite, we can have the final result, the final outcome is very good. And if you see the result of this clinical case, especially, I was changing the shape and closing the spaces, and the final result is pretty good. The question that I always have is how we keep this composite without the staining during the time, and how we keep this composite without the fractures. So we have one challenge actually. So we have to learn how to keep the surface. If you check the 2 years result, this is a 2 years follow-up, we can see that usually we have this staining on the surface, and also we have this plaque adherence on the surface. So if you check in 2 years, this is something that is pretty easy to see. The first challenge is we have to get a way to keep the surface. I'm going to show you how we keep this during the time. But usually if you check 2 years, and also in this case, I'm going to see in the 4 years result, usually we have a little bit of staining. We have to maintain the surface during the time. Composite is not a procedure that you can finish the restoration and you keep without this maintenance procedures, and this is something that we have to learn how to deal with. This is the 4-year result. I can see also in the, if I check the 6 years and a half result, I can see as well. Okay, so we have the composite, we can keep these restorations, but the question is how we keep these without a staining and without the fractures. All the papers that we have discussing composite for interior restoration, we can see that this repair and this maintenance, this is something. This challenge that I told you basically is how to repolish these composites during the time. So uh, the first part is the repolish procedure. We have to do that once in a year. So after all the restorations, usually this is something that we do. Basically, this repolish is going to be done with 3 steps. The first step, I use a rubber system. The name of this rubber system is Astropol from Ivoclar. We have 3 colors of rubbers. The first one is the gray, the second one is the green, and the third one is this pink rubber. So in this repolish appointment, I just use the green rubber and also the pink rubber. So this is the first step. I use the green and the pink rubber of Astropol. The second step in this repolish procedure, I use this Epitex strip. This is a very thin strip from GC. I have to mix this very thin strip with a diamond paste. Usually a diamond paste is a paste used for ceramics. This is the second step. With this very thin strip and this paste, I can remove the staining of the interproximal area. And the third step is going to be the use of this floss. This is from Procter & Gamble. We have many brands for sure, but this is something that we use for ortho patients. And I mix a little bit of diamond paste in this floss. So these are the 3 steps for the repolishing. We have to do the repolishment once in a year. Okay, this is something that helps us to keep the composite. And if you check this patient, especially, you see the after result, 4 years result. This is something that sometimes we notice with composite, especially in the anterior area. Sometimes we have to repolish this, and I show you the way to do that. The second thing that we have to learn how to do with anterior restorations is sometimes we have to repair, and repair is something that is easy to do. I'm going to show you the steps of this composite repair. This is a K9 to K9 reconstructions done with 4 seasons. This is the old composite from Ivoclar. If you see this result, this is 2 years after the composite restoration. I have a small fracture. So I'm going to do the steps for the repair. The first step for the repair is I have to promote this roughness of the surface with a diamond burr. The second step is going to be the sandblasting with aluminum oxide. The third step has to be the acid etching with phosphoric acid. So this is very simple. The fourth step of this repair, I apply the same silane that I use for ceramics. So I apply on the composite, on the old composite. This is the fourth step. The fifth step, I apply the adhesive on the surface. And the sixth step is the repair itself. So we learn how to do the repolishment of the composite, of the old composite. This is something that we understood. And now we know how to repair this composite. I show you all the steps to do that. After you finish the repair, you can do all the steps of the repolishment also. So you can do both procedures in one time. So if you see the final outcome of the repair is something that is pretty good, and it's pretty reliable. We can repair composite, we can keep that during the time. So I told you about this challenge of anterior restorations that was how to keep and how to repair. We know already. If you think we understand that in the day-to-day we have some reconstructions with composite that we keep for a long time. So this is a patient that this is in my new book that is coming with quintessence in English. But if you see the final outcome, this is in the left side after result. This is 16 years after. This is 18 years after. And if you see after a repair in all the composites 21 years after, this means that we are keeping these restorations during 21 years. So this is something that is pretty good for composites. So this is the patient, the after that I show you, and then during the time we can keep this old composite. Okay, many times we have these anterior reconstructions and we can think about a transition to ceramic. This is not a problem. This is a case that we done with the Tetric Evoceram. We were increasing the size and the length of the tooth, closing also the spaces. And if you see the end of the restorations, the final outcome, it was very good. I did all the polishing procedures, the polishing steps, and the final result of this composite was pretty good. It was very polished. And if you see the surface, the texture of the surface was pretty good. And I have this follow-up of 4 years of this restoration. So this is after, and I want you to see the result 4 years after. So 4 years after, I noticed that I have a lot of staining. It's not because of the composite, but the patient told me that he used to like after work, he used to like to smoke a cigar every day, and also he used to like to drink red wine, so after work. So this is something that for composite is pretty difficult to keep the surface with this kind of staining. So in this patient, we decided to change and we promote the transition to ceramic. We remove all the composites after 4 years, and then we replace for ceramic veneers. This was done with the IPS design. This was canine to canine. This is the after result, and we have the follow-up of 2 years. So it's not a problem to think about composite, even if in the future we are thinking about this transition to ceramic. This is something that is very common as well, and is not a problem. Okay, so the first part, the first challenge for composite was how to keep that and how to repair. We know already, we understood. So we have one problem with composite that is pretty much the technique. When you think about anterior reconstructions, and if you see the video of the reconstruction, you understand that to create all the natural aspects of the tooth, to close the spaces, getting a very smooth surface. These three teeth I did alive in a dental meeting, and after that I finished the other three tooth. I finished K9 to K9. If you think about the technique of anterior composite, the problem is that the technique is still too difficult. If you check this graph, you can understand, because the operator one actually is one person, is a girl. She was a DDS student. On the right side, you can see the operator two. This was a professor from another country, from Chile. He was doing postgrad at NYU. And if you see the both operators, you can see the difference on the standard deviation of both. Both operators, they were working in the same restoration, and you can see the difference in the result. So the problem of composite is still that the problem of the technique is still too difficult to do. So the first challenge, that was repolishing and repair, we understood. The second challenge that we have is we have to simplify the technique. I like pretty much this composite system is what this system is called Empress Direct, and basically is a very static system. I can use dentin plus enamel, getting very good results. So nowadays the technique for anterior reconstructions are easier than before. And if you check the old composite from Ivoclar, it was called Four Seasons. If you compare to Empress Direct, you understand that the system nowadays is much more simple than was before. So the second challenge that I told you, we have to simplify the technique. And this is something that we understood. With Four Seasons, that was the old composite from Ivoclar, we used to have many color and many layers. We used to have a very good result, but basically the problem was that the technique was still too difficult. What we got from this new composite that I told you, that is Empress Direct, is that we can have still the same very good optical properties, but we have a very simple technique. We use dentin plus enamel, and this is enough. And in many cases, as we can see in this case, if you have thin layers, we just use enamel and you can have a very good result. In this case, I just use Empress Direct A2 enamel for erosion case. This was a patient with erosion on all the anterior teeth, and we just promote the reconstruction with this enamel layer. If I check the third case, this is the third case, I am just changing the composition of the anterior tooth with just one composite, just enamel composite, with a bleach patient. And I like very much this color. There is the XL enamel from Empress Direct for bleach tooth, especially for reconstructions. And if you see, the final outcome is pretty good. So this second challenge that I'm telling you now is that we have to simplify the technique. And this is something that we got already for anterior reconstructions. So this is a very good final result. Maybe in the future we're gonna also have ways to sculpt the tooth in an easier way. We have a pilot already in the market. The name of this system is U-veneer. You just feel inside this matrix, is like a stamp. You fill the stamp with a composite, and then you put this stamp on the position. And then you can have the sculpture of the tooth promoted by this stamp. This is a pilot. That means you don't have many anatomies, you don't have texture. It's a very simple way. But in the future, I agree that we're going to have more options for this kind of stamp. This is something that could be a very good choice for the clinician, avoiding the sculpture handmade and just by the using of one stamp. In this case, I use this stamp, this matrix, with just one color of composite. It was Empress Direct A1. And if you see the final result, sometimes I think that for general dentists, it's going to be a very good choice, okay? just using a simple composite system, and in this case, using some matrix for the sculpture of the tooth. Okay, so a summary for the anterior restoration is going to be what kind of materials do we need for anterior reconstructions? Basically, I use Empress Direct composite. I have a choice to use if I want the Evoceram composite. So this is a matter of choice. I think that for static situations, I think that the Empress Direct is going to be better. You have better aesthetic outcome. Besides the composite, you have these two choices. I can use an adhesive. I will discuss a little bit adhesive with you, and a very good curing light. So if I want to set for anterior restorations, basically what I need is Empress Direct composite. I can choose if I want to use the Evoceram. I need an adhesive system. I can use this universal. I will discuss that. And a very good curing light. This is a summary for the anterior tooth. Okay, the second part of the lecture is the discussion of the posterior area. So composites for posterior. Basically, we can trust in the results. If you check the composite that we have so far and you see the follow-up, this is something that we have already. We have a very good result in the clinical evaluation of this kind of situation. This is a patient that I did a long time ago. This was in 1997. I changed this old amalgam with composite. At that time, the composite was tetric serum. Okay, this was the first tetric serum. If you see the restoration, this is step by step. I'm going to discuss that later. But this is the final restoration. This is immediately after. And if you see this composite compared to 11 years after, I can see some changes on the surface. I can see that usually composite loses the shiny surface, the shiny aspect. Sometimes I can see some abrasion on the surface. But if you think about a restoration, I think that the restoration is still in function. And if you see the interface, I can feel that is still in function. The interface is still sealed. That means I have a very good result and I can trust in the follow-up of the restorations. This is the composite 15 years after. If you check 15 years after in the X-ray, I can see that interface is still sealed. So this is something that is very reliable. Let me take a second case and then we keep discussing that. This is the second case. This is the replacement of the amalgam with composite. This is after. This is on the right side 11 years after compared to after result. This is the composite 15 years after. If you see the X-ray is still sealed. And this is the composite 18 years after. So the question for posterior restorations that I began was if we can trust in these composites for posterior. And this is something that we have already. We have the result in the clinic. This is something that we trust, and the results are pretty good. If you check the papers, what we have about follow-up, about evaluation, clinical evaluation of composite, we have already scientific data. We have the result. And this is a very good paper, but this is one example. We can trust in composite for anterior and also for posterior. What we have to understand is this. I'm going to show you in this case. This is a case that I did with tetric serum, the old one, with adhesive. At that time, this was the beginning of the self-etching concept. And this is something that I think that's going to be the trend. So basically, I was beginning to work with this adhesive with a self-etch concept. Okay? So I am changing the composite. I'm doing it step by step. We're going to discuss later the step by step. This is the result. 1 year after, 3 years after. When I call the patient 8 years after, I need an SEM. a microscopy of the surface. I want to check the surface of the composite in the SEM. And if you see this composite under the SEM, I can see that you have already the abrasion of the composite. You have some changes on the surface and also interface. But if you see in the natural tooth, I can see that as well. And if you pay attention on the interface is still sealed. And all the papers say that usually composite is different from metals. You're gonna see some irregular surfaces and also interface. It doesn't mean that is a failure. It's part of this restorative procedure. This is something common. You don't have to worry so much. The interface is gonna be a little irregular. You don't have you don't have to repair the interface. This is something that is okay. 10 years after, I can see some staining on some parts of the composite. The interface is still sealed, and I don't need any repair. Okay, but I have to understand that all the results of composite depends on adhesives itself. I can use composite, but it's better for me to use composite only with adhesive, without any base. That means without a glass ionomer as an interface or without calcium hydroxide as an interface. Okay, it's always better to use composite only with adhesive layers, and this is something that we have to accept. If you check all the clinical evaluations of composite, usually the results for composites used only with adhesives are always better, and there's one explanation for that. Always the result is better because the adhesion, the bonding strength of the adhesive, dental adhesive, is always higher than the bonding strength of the glass ionomer. So this is something that we have to understand. We can trust in the result of composite, but we have to learn how to use that only with dental adhesives. So this is the message. So my question to you is, can we trust in dental adhesives? This is a patient that he decided to close his spaces himself. He decided to close with super glue, and this is a 5 years follow-up. He did himself. So my question to you, this is funny and this is strange, but this image is just to make this question. Can we trust in adhesives? Because I told you that the result of composite is related to the use only with dental adhesives. So I will discuss just two problems that we still have with composite using dental adhesives. The first problem is the post-op sensitivity with cold. And this is something that happens after restoration. So when I have this problem, usually if you see this case, you're going to understand better. I am changing a restoration. I am doing this step by step. I will show you how to do that after, but I'm finishing the restoration, and if you see in the interface of this composite, I can see this white line. Always when you see this white line, it means you have a gap formation. You have an interface. Every time you see some white line around the restoration, this means space. This means gap. So usually this problem is generated by the adjustment. We use too much adjustment using diamond burrs, and we should use more carbide burrs. I'm going to show you the carbide burr that we use. But in this case, I had this problem after the adjustment. I can see this white line. When I'm doing the adjustment, I can see this white line. That means gap formation. This is the cause of this post-op sensitivity. Every time your patients say, I feel a little bit with cold, this means I have a problem on the interface. And usually this is created by this excess of the adjustment, using too much diamond burr in a high speed. So ideally you should adjust less. Ideally you should use this burr. This is a carbide burr from Brosseler. The reference is H379. And ideally you should use this burr with low speed, not with high speed. So this is the best option. Okay, this is a way to avoid this post-op sensitivity with cold. But if you have already, okay, you had this problem and your patient feels this sensitivity, the way to solve the problem is this. If my patient have this sensitivity, he has this sensitivity with cold, the way that I do the procedure is I have to etch all the interface with phosphoric acid as this paper. Okay, this is a reference of this technique. I have to etch all the interface with phosphoric acid. I wash, I dry, and after that I have to apply a very thin dental adhesive. This adhesive will penetrate this interface and is going to seal this interface. So the cause of this post-op sensitivity with cold, we know already, okay, is interface, is an open interface, is a gap. And we know already how to avoid that. And if I have this problem, I know how to solve. So this first problem of dental adhesives is very simple, and I think that you can manage this. The second problem that I have with adhesives is another sensitivity that I can say 1 week after the restoration, my patient come to my office. This is a follow up, and he says, I feel a little bit when I bite something. This is a different sensitivity. Uh, the sensitivity when your patient bites something, this is a problem of the adhesive application. This is a problem of the adhesive layer. If you see this problem in the SEM, basically is this image. On the left side, you have the dentin. On the right side, you have the composite. This is exactly the interface of the restoration. And if you see in the left side, you can see some failures in the penetration of the adhesive. These failures are basically these spaces. You demineralize the dentin, you expose the collagen, but for some reason your adhesive doesn't penetrate on these spaces. And when your patient bites on these failures, on these spaces, he feels like a bite sensitivity. I have some ideas about that. The first idea that I have, why we are having this kind of failure, how I'm getting this kind of sensitivity, why? The first idea that I have is because we are etching too much time the dentin. Sometimes you are etching too much. You know that in the past we used to etch the dentin for 30 seconds. 10 years ago, this time changed for 20 seconds. Nowadays, the time that we use for the dentin etching, if you want to etch the dentin, is 10 seconds. We are changing this because when you use too much time for the etching, actually the problem is that you demineralize too much. You demineralize too deep, and your dental adhesive doesn't penetrate so deep. And if you see in these images, you can see on the left side, 10 seconds of etching on dentin. On the center, 30 seconds. On the right, 60 seconds. On the red image, you can see the areas that you have a failure on the penetration and the sealing of this dentin. This means when you use too much time, you have a problem to seal all this debt that you promote the demineralization. So basically, I have one idea. We are etching too much time. We are etching too much the dentin. This is the first idea. And if you see the way that we apply the acid in a large cavity is difficult to control because you apply the acid in the mesial cavity. After that, you apply the acid on the occlusal cavity. After that, you apply on the distal cavity. And then you count 10 seconds. So this means it's difficult to control in the day-to-day, the time of the etching on dentin. I have a second idea. My second idea is maybe you are drying too much the dentin after the acid. And we have some papers that discuss that. You have a problem of the adhesive penetration if you dry too much the dentin. And also I have another idea. You can sometimes wet too much the cavity. Sometimes you keep the cavity too much with moisture. You keep too much water in the cavity because you are worried so much about drying too much, and then sometimes you keep this water inside the cavity. And every time you have too much water, the problem is that you cannot polymerize adhesive with water. So you have both problems. You can dry too much or you can keep the cavity too wet. And these two problems can cause the same failure of penetration of the dental adhesive. So far we have three ideas, three possibilities. The time of the acid action, dry too much the dentin, you keep too much moisture. And I have a fourth idea. Sometimes we don't wait too much time, we don't wait enough time for the adhesive to penetrate the depth that I promote the demineralization. So I have four problems that I have to solve. I'm going to show you how to deal with this. This is the challenge number 3. We have to simplify that. And the way to simplify all of these problems is using a self-etching concept. That means we don't etch anymore the dentin. We prefer always to avoid the acid etching of the dentin. We keep we keep the acid etching on enamel. The acid etching on enamel is still a procedure that we do. We do this acid etching on enamel for 20 seconds, 15 seconds, but we avoid this acid application on dentin. This is the best way to avoid the adhesive failures. And after etching only the enamel, you wash, you dry the cavity, the best way is to use some adhesives that you can apply without the etching of the dentin. Nowadays we have these universal adhesives like this universal. That means you can apply this adhesive without the etching of the dentin surface. And I think that this is a very good idea, okay? This is the third challenge, a way to simplify adhesion and avoid the post-op sensitivity and the problems, okay? Okay, all of this information basically you will find in this book. This book is coming with quintessence in English, and you will find some videos of these procedures in the app, okay, that I showed you before. Cool. So far we discussed anterior restorations, how to repair, how to repolish. We discussed also a way to simplify anterior constructions. After that, I began to discuss posterior tooth. You understood that it's very reliable. It's a reliable procedure. You have to trust in dental adhesive. And now we show a way to simplify the adhesive steps using self-etching adhesives or universal adhesives. The next step basically is a way to, we have to simplify also the posterior technique. So if you check these draws of Picasso, all of these draws basically were done with just one line. He used to put the pencil in one point until the last point. This is a very good idea to simplify the technique. We have to change this time that we used to work with a lot of closet, and I think that we can simplify nowadays. And this is a good idea for posterior too. Traditionally, that means the traditional technique for composite used to be many steps. You used to apply many layers to control the shrinkage of the composite, especially inside a inside an occlusal cavity, class 1 cavity, class 2 cavity. And this traditional technique is something that we can change. This is the fourth challenge. Let's simplify the traditional technique. The traditional technique, I told you that we have to use too many steps. I think that the way to simplify this technique is using bulk fill composites. And the bulk fill composites are special composites, that means are composites with new monomers or new initiators that allow us to use until 4 millimeter thickness in one way, in one layer. That means I can fill all the cavity until 4 millimeters and then I can cure for 20 seconds. This is a very good way to simplify the technique. And this is something that I will show you in this case. What we do nowadays, we just remove the old composite. You know already that we don't etch the dentin, we just etch the enamel for 15 seconds, 20 seconds. After that, I apply a universal adhesive like this. This is a this universal. After applying this adhesive, I will polymerize this layer. And the way that we use for restoration, posterior restoration nowadays, is filling all the cavity with a bulk fill flowable composite, leaving just a small space for the last layer. The last layer will be a regular composite because this flowable bulk fill doesn't have enough resistance to be on the occlusal surface. But after curing this bulk fill flowable composite, I just finish the last layer with a regular composite. I can use some stains if I want. I will discuss that later. But the technique itself is going to be easier and faster. A posterior restoration will be done just with 2 layers. The first layer is going to be a bulk fill flowable composite. The last layer is going to be a regular composite with staining or with this stains tints or not. These 2 steps restoration is something that's going to be easy for us in the day-to-day with the same results that we used to have in the regular technique, in the traditional technique. For that, I think that you have to understand something about this bulk fill. The idea that I used to have about doing too much layers to control the interface, these old papers actually began to discuss the efficiency of using too much layers to control the shrinkage. It was not so true that I control so well doing too much layers. I have these are old papers, but I have a newer one. This is done by a friend of us from Brazil. But if you check this paper, it's something interesting. If you see the images on the left side, using too many layers with a regular composite, sometimes you have more stress on the interface than using bulk fill composites. So the first idea for me of a bulk filling of a cavity is that I can have a very good result of this interface without stress using just 1 layer. This is the contrary of what I used to believe in the past. The second idea about using bulk fill composite is that when I do too many layers, usually inside the composite, I begin to increase the number of the failures, like bubbles and voids. This is something that I don't see, but if I check in the X-ray, this is something that I notice. If you put too many layers, you begin to increase the number of the voids and failures. And I think that using bulk fill composites, this is something that also you will avoid. This is the second advantage of bulk fill. The third advantage for sure is that you're gonna have less steps than the traditional technique, as I show you. So for instance, you wanna use a bulk fill composite in the base, you're gonna use until 4 millimeters, leaving just a small space for a regular composite. This space is gonna be 1.2 millimeter thickness for a regular composite. 1.2, 1.5, okay? In this technique of bulk fill composite, and we did some research on these bulk fill materials, you have less shrinkage with these materials, you have less stress of shrinkage, and what you see in the interface is something interesting in the research. If you see these images of the bulk fill composite from Ivoclar, the flowable one, these are 3D images of restorations. And if you see in the green, the green shows us the shrinkage. So if you see these cavities filled with bulk fill flowable composite from Ivoclar, Evocera, you can see that you have a small shrinkage only on the occlusal surface, but all the interface is sealed. And if you compare this with a regular composite, for instance, this is a composite from 3M, this is a regular one, not a bulk fill one. If you see the shrinkage of a regular composite is gonna come in the occlusal surface and also in the interface, especially on the bottom of the cavity. And this is something that we have to avoid. So these images just show us the idea of these bulk fill materials that you can apply until 4 millimeters. You have the polymerization until 4 millimeters, and you keep the interface sealed. And this is interesting. So we published this clinical paper that was the idea of filling a cavity until 4 millimeters in one way. We polymerize for 20 seconds. And after that, we just apply a final layer of a regular composite. We do the sculpture. If you want to do also the staining of the sulcus, or you want to characterize the restoration, this is something that you can do as well. But you agree that these two steps is gonna give us a very fast procedure and an easier step by step. So what is the idea now for us? We just apply the first layer of a flowable bulk fill composite. Can be this one. This is the Tetric Evoserum bulk fill. You just leave a space for a final layer. The final layer is going to be like 1.5 millimeters, 1.3, 1.2, around this thickness. And the final layer can be a regular composite. In this case, I am using the Evoserum A1. In this technique of bulk fill flowable composite, is basically two layers. The first layer is a bulk fill flowable one, and the last layer is going to be a regular composite with a very good result. Okay, so basically the advantage of this is you have a very fast restoration, you have less shrinkage on the interface, and also I told you that you have less bubbles inside. The EvoFlow bulk fill, this Tetric EvoFlow bulk fill, has an advantage of changing the opacity after curing, because usually the bulk fill materials, they are very gray, they are very translucent. There is one advantage of this EvoFlow bulk fill. After I polymerize, opacity increases like a dentin layer. And this is interesting because sometimes when we are working in a cavity like this, you remove the old composite, you have some staining on the depth of the cavity. This kind of bulk fill flowable composite, as it changes the opacity after curing, you can hide the color of this stain on the pulpal floor. And if you see before curing and after curing of this Evoserum bulk fill, this is something that you notice. You can have the opacity of this bulk fill flowable like a dentin, so you can finish the restoration in an easier way. So basically my idea for this simplification of the technique with for posterior restoration is using this flowable bulk fill composite. Basically, I'll give you a tip. You just need this color of bulk fill composite. The most used bulk fill composite is the IVA color. This color is like a universal color. So you don't need to use too many colors. Basically, I use just this IVA color of Evoserum bulk fill. And the last layer, I don't change too much. Usually I just use this A1 Tetric Evoserum color, okay? So this technique is gonna be two layers. The first layer, the IVA color of Evoserum bulk fill, and the last layer is gonna be the Evoserum traditional one, just A1. You can apply some stains, and this is just an option, okay? Well, basically, if I give you the summary of this posterior restoration using bulk fill, what you need basically is a tetric Evoserum composite for the cap, for the final layer. You need the Evoserum bulk fill flowable for the base. You can use until 4 millimeters. You need this universal adhesive that I told you, adhese universal, and a very good curing light. This is a summary for this posterior restoration. Let me give you also another option. If you, because you remember, imagine that you bought already the Empress Direct composite for anterior restoration. You can use as well this composite for the cap of the restoration. So I can give you an option instead of using the Evoserum composite as a final layer. If you have this Empress Direct, can be also the Empress Direct, okay, as a final layer. So I gave you two options. These are the summaries for the bulk fill flowable technique. Let me give you the last tip. Maybe I have time enough. Let me see how much time I have. I have, okay, 8 minutes left. So I think that I can give you another tip. There is, you know that you have some bulk fill materials that are not flowable. They are regular. 5 minutes? No, I'm cool. 5 minutes? No. You know, I think that 8 minutes is good enough. Don't worry. Let me see. You know that you have this bulk fill composite, but the consistency is not flow. But basically, they are regular composite. They have the same resistance. Basically, the same resistance of a regular composite. They are bulk fill materials. That means they have different monomers and also different initiators to control the shrinkage and also to promote the polymerization until 4 millimeters. But you don't need to lead a final, you don't have to cover this material with a final layer of a regular composite. You can do all the cavity with this material. So let me show you this. In Latin America, this is sold as tetric Anserum, but in US, it's going to be Evoserum bulk fill. It's a bulk fill material, but it's a regular consistency composite. What is the idea? I have tested already this material as well, and the result is pretty good. So what is the idea for this kind of material? Let me tell you. I remove an old composite, I do the prophylaxis of the cavity. You know already that I prefer to avoid the acid etching on dentin. I just apply the acid etching on the enamel, okay, for 15 seconds, 20 seconds. I wash, dry. After that, I apply this adhesive. This is the adhese universal. I polymerize this layer. And now with this tetric Evoserum bulk fill regular consistency, I can fill until 4 millimeter thickness cavity, but I fill that in one way. I don't have to leave a final space for another layer. I do everything in one layer. If I want to use some stains like this, these are the Empress colors. These are stains, tints that I use just to characterize the restoration. And if you finish the restoration, basically just in one polymerization. So I gave you actually two options to simplify the traditional technique. Using a flowable composite, bulk fill, this is something that I like very much, and this one, using just one composite. Let me tell you something. I use this kind of material more for these three situations. The first situation that I use more, the regular consistency bulk fill, is for a small class 1 restoration, okay? When I have small class 1s, I prefer to do that in a fast way, faster, so I can use this kind of material. The second situation that I can use this material is for pero. That means for children, I think that it's pretty easier to use this kind of bulk fill material. The third situation that I prefer to use this bulk fill composite, regular consistency, is when I don't use rubber dam. When I am not able to use rubber dam, for instance, a third molar or a second molar, upper second molar. When I am in a clinical situation that I don't use rubber dam, I think that this is my choice, okay, for composite and for technique. For this regular consistency bulk fill composite, the summary will be what I need to do this restoration. I need the Evoserum bulk fill. Basically, the color that I use most is the IVA as well, okay? I need the universal adhesive to avoid etching the dentin, as I told you before, and I did a very good curing light. So this is a summary for the regular consistency bulk fill. Let me finish this lecture with one information that is important for us nowadays, because all the summaries, you notice that in the end, I referred to a curing light, a very good curing light. This is something that we don't pay so much attention in the day-to-day. We are discussing polymerization through 4 millimeter thickness, composites. We are using composite in many situations, and this is something that we have to discuss. There is the curing light. Let me show you something. All the composites, they use this initiator. It's called camphoraquinone. Okay? The wavelength to excite the camphoraquinone is 460 or 470 nanometers. That means this is the blue light. All the current lights, they offer us this kind of wavelength. They are able to activate the camphoraquinone. This is not a problem. For instance, Demi from Demetron, this is something that we have. The problem is that the color of this initiator is yellow. That means there are many composites and many resin cements that don't use so much camphoraquinone. For instance, bleached tooth composite or a very transparent resin cement, for instance, they use less camphoraquinone. They use more another initiator. Let me tell you, for instance, the most used one. It's called Lucerin. But if you check the wavelength to excite the Lucerin, is 380 nanometer. This means that the regular lights, they don't promote the activation of this kind of initiator. This is the problem that we have nowadays. The regular LED lights, the current lights, they don't polymerize so well some kind of materials. For instance, a very bleached color composite or a very transparent or bleached resin cement. This is something that we have to pay attention. There is a way to solve this. And the way to solve this, basically, these were videos I was showing in these videos that the regular lights, they are not able to polymerize composites that use more Lucerin, okay? And the way to solve this problem basically is using light that give you two wavelengths of excitation. That means activate the two wavelengths, activate the two types of initiators. One example of this type of current light is blue phase from Ivoclar. Any type of blue phase, you have the blue phase style, you have the blue phase 28. Doesn't matter the series of the blue phase, but all the blue phases, they allow us to polarize in two wavelengths. The second option is besides blue phase for sure. The second type of light that provides us two wavelengths is the Velo from Ultraden. But it's just for you to understand that we are paying so much attention on the material, adhesive, but also you have to pay attention on the curing light. Remember again, we are curing through 4 millimeter thickness composites. We are using very much composite for anterior reconstructions and anterior situations. And many times we are using much more bleached tooth color composites. That means we have to pay attention and we have to get a very good curing light as well. And some papers already show us that this type of polywave curing lights, these are the only two polywave lights so far. They can polymerize better some types of resin cements nowadays. I think that basically this was the idea for this lecture. Okay, discuss basically composite restorations for anterior and posterior. Remember that I gave you some ideas to simplify the technique. And I think that this is the best way to get a standard procedure for the day-to-day, not only for anterior, but also for posterior. If you want my personal email, usually I give you this email. I think that is easier for you to send any information that you want. But I think that I have some minutes to answer some questions, and I have 30 questions already. 4 minutes. 4 minutes. 4 minutes for 31 seconds. Okay. Let me see. Let's see. I will choose some questions. Let's see if I can answer. Okay. Okar Feijo. The question is, could you explain about finishing composite? Okay. Let me tell you something. Okar, let me give you a fast way, a way to do the finishing and polishing for posterior, okay? The posterior restoration I use first, that carbide burr, the name is H379 from Brussels, remember? The second step for posterior, I use a diamond paste with a prophylaxis brush, okay? Because posterior restoration is difficult to use rubbers because of the anatomy of posterior tooth. So my second step is a paste, a diamond paste with a brush. And my third step is the use of the Astro brush. Astro brush is a silicon carbide brush used just for the polishing of the surface of the composite. So the third step for posterior always is a carbide brush, like Astro brush, okay? For anterior, I would say that I always begin using a disc. I like the Soflex disc from 3M for finishing, not polishing, for finishing. After the disc used for finishing, I like to use the Astropole. I begin with the green, the gray. After the gray, I use the green. After the green, I use the pink, okay? After the pink, I finish the anterior polishing with a paste. And usually I like a paste from Cosmedent. The name is Enamelize. Enamelize is from Cosmedent. It's a very good paste for anterior. So I think that this was the question. Let me take a second question. Monica de Leon. In class 2 posterior restoration, you use bulk fill as well. Okay, let me tell you something. I can use bulk fill materials for class 2 as well. I personally prefer to reconstruct the proximal cavity with a regular composite, okay? So I like to use bulk fill materials for class 1. For class 2, personally speaking, I prefer to reconstruct this proximal wall with a regular composite before, okay? This is my personal option. Because some of the flowable materials, for instance, SDR from Dentsply, Surefill SDR, is a flowable material. If you leave this material in the external surface, the polishing is not too good, okay? So imagine that you leave this composite in a class 2 cervical area. The polishing is not very reliable, okay? This was the question. Is tetric evoceram flow better than the conventional tetric evoceram? This is from Rana Via. Let me tell you something. Tetric Evoceram Flowable is good for you to use just inside the restoration. So for the inside of a posterior restoration, I think that is very interesting, more interesting than the traditional technique using too many layers. But I will still use the Evoceram conventional for the last layer, for the cap. Okay, so this is the answer. Let me take another question. I have time still. Please, what is the name of the app? The name of the app is Ronaldo Hirata. That is very creative, but it's Ronaldo Hirata. Do you use, let me take this question, Gilberto Mendes. Ah, no, okay, I don't have time enough. Okay. Oh, okay. I'm sorry we don't have time enough for all the questions, but if you want to send me questions by mail, it's going to be cool. So thank you very much. Have a good night and also a good week. Okay? See you. Best.